Thanks for joining us today. We are going to start off with just quick introductions, if you don't mind. So we'll start with you, Max, all the way at the end.
Thank you.
And what you do.
Thank you for being here with me. My name is Max. I'm leading what we call value creation in the consulting team inside Siemens Healthineers. We are supporting investors, project sponsors, and all kinds of new endeavors, entering new markets, putting new hospitals together, putting new projects together. That's what I do globally.
And you've been doing a bit of work in remote patients and telehealth and all that sort of stuff, right?
Absolutely. All the solutions that we're implementing are kind of, have a telehealth component these days.
I had to check because that's what the title of the session is. Valentina.
Hi everyone, I'm the founder and CEO of Daye, and we are a gynecological health management platform dedicated to bridging the gender care gap. We started with the invention of novel medical and diagnostic devices for underserved women's health needs, and our main hypothesis is that we can repurpose an existing device that billions of women use already on a regular basis, the tampon, to do a lot more than just soak up menstrual fluid. So we started with the invention of the world's first pain-relieving tampon for localized primary and secondary dysmenorrhea relief, and more recently we introduced a diagnostic tampon for at-home STI, vaginal infections, and HPV for cervical cancer screening. Alongside these physical products, we've also created a digital aftercare platform that enables remote consultations with nurses and obstetricians, as well as prescription treatments. And we're active in the US and the UK.
Super. Tomas.
Good morning, everyone. It's a great pleasure to be here in Barcelona, and I really enjoy the time with you. So, my name is Tomas. I'm a cardiologist from my background, but I'm also acting as a director for public health research and education at a university hospital, which is located in Lithuania, in Kauno. So we just serving for our patients as the largest healthcare institution, not only in the country, but in all Baltic region. I'm also president of the Lithuanian Society of Cardiology, so extra work.
So not an overachiever in any way, right? Very good. So it says here on the, our experts will spill the beans on seamlessly integrating telehealth into daily practice, cranking up patient engagement and crushing the unique challenges of remote care. Max, are you crushing the remote care challenges with what you're doing at the moment? Give
Absolutely.
us some examples.
I mean, as I said, I think many of the projects that we see implemented, and it can be anything from really putting a hospital together up to implementing remote care in Africa. All these things have a telehealth component these days, I think. And I think there's some of the more traditional angles that we're going to cover, which is, this doctor-patient interaction in the end that happens remotely. But I think we should also cover a different angle, which is, I think, an efficiency in workflow perspective and workforce perspective also. Because that's kind of a component that is also being looked for. For many hospitals across the globe, they're struggling with getting their workforce together. So once you know that there's a patient population you want to serve, question is, how do I get my doctors in? Can I get enough qualified nurses to serve the people that I want to serve? Telehealth can be also a remote solution that helps, bring qualifications to different places at the same time, or at least in a shorter time frame, because things happen remotely. Can be a solution that helps you do a proper CT exam with less qualified staff on the spot, right? Can be a preparation video that helps patients actually prepare their GP visit before they go, so that the experience is better, or that it runs more efficiently and smoothly, right?
So you're broadening the word telehealth into other pieces. It's not just the exchange
exactly.
At that moment.
And I think that's how we should think about telehealth in the next years to come. That we don't just think of that app where I can speak remotely to my doctor, which is basically, we have that. It's called WhatsApp, right?
So what other add-ons do you have to keep that engagement going?
Sorry?
The other add-ons that you're putting on to get the engagement going, and then the education of the patient. That's where this is heading, is what you're saying.
Yeah.
Okay. Valentina, you're doing things directly with patients. That's how you started. Is there a difference? Do you find the satisfaction rates better? Give us the history of how you got going and why you started this.
So I started the company really inspired by my own personal gynecological health horror stories. I had extremely painful periods when I was a young child, and then that progressed to ovarian cysts. And there wasn't a scientific consensus on whether to operate on these cysts or not. So, I would be admitted into hospital, prepared for surgery the next day, and then in the morning, the next shift of doctors would come and say, actually, of course, we're not going to operate on this. The previous people didn't know what they were doing. And initially, I just thought, okay, I'm very unlucky. I just have, bad experiences. This is unusual. But then I had conversations with my friends and my peers, and I realized that the standard in women's health today is just incredibly low. And this opened my eyes to the gender research gap and the gender care gap, the fact that women were not allowed to take part in clinical trials up until 1993 in the US and 1995 in the UK and Europe, means that we know so little about how to diagnose the female physiology and how to treat the female physiology. And still to this day, we're really struggling with recruiting women to clinical trials. The infrastructure that we have in place is really designed for young, white, university student males. It's not designed for racial diversity, is not designed for sex-based diversity either. So what I wanted to do with Daye is to focus on underserved, trivialized women's health conditions, like period and pelvic pain, for example, which affects 90% of the population. It's a silent public health pandemic, but since the moment a girl has her first menstrual cycle, and if it happens to be painful, all that you are taught is this is normal, it's just preparing you for the pains of labor. If you can't survive your menstrual pain, what kind of a woman are you? How are you ever going to deliver a baby? And I really just wanted to question the status quo and to turn it around on its head a little bit. So we started with the pain-relieving tampon, providing localized menstrual pain relief, because actually the vagina is the safest and most effective way to deliver medications in women. You bypass the digestive tract, you bypass the liver, you disengage these two systems, and when you give a medication vaginally, it works faster, you can use a lower dose, it's safer, etc. And that's what we created at the beginning. And then from our community, we learned that there's another issue with period and pelvic pain. It's not just the issue with treating it and the fact that we don't know how to treat it. There's also an issue with the diagnoses. So across 700 different diseases, women get diagnosed later than men. For cancer, it's 3.5 years later. For diabetes, it's 4.5 years later. But for female-specific conditions, the average delay is 7 to 10 or 8 to 12 years. This is a really long time in which we let the disease progress. We don't treat it. We don't support the patient's symptoms. But for example, in the case of endometriosis, it grows to stage 2, stage 3, frozen pelvis, etc. So the second service that we introduced is a virtual diagnostic that matches your symptoms of your period and pelvic pain to endometriosis, adenomyosis, fibroids, polycystic ovarian syndrome, and presents you with answers on what's causing your pain, and then how can you treat it in a personalized way.
So do you do that directly with the patient? Is the patient interacting with a doctor that works for you? How's that work?
The patient always has the option to interact with a specialized nurse or a specialized obstetrician. One of the biggest misnomers in modern medicine is that obstetrics is a specialization. It's really not. We need people that are specialized in menopause, doctors that are specialized in polycystic ovarian syndrome, but the modern medical educational system does not facilitate that at all. In fact, we spent an overwhelmingly tiny percentage of medical training on women's health. So we provide trained nurses and trained obstetricians who specialize in niche women's health conditions, so they can really deliver custom tailored care. But the patient accesses the care on their own terms, so they don't have to engage with a doctor or a nurse if they don't want to, which is something that we've seen in women's health overwhelmingly. We just don't trust the medical community. We don't trust doctors, we don't trust nurses, because a lot of women have been gaslit for a very long time. They've been told to accept their pain as normal. They haven't received answers. So a big part of the challenge going forward is going to be how do we enable the female patient population to regain trust in the medical system.
And is it available, what, are there hours that you do this? Can I talk to a doctor at midnight?
No, you can't
Okay.
talk to a doctor at midnight, but we do same-day appointments.
Okay,
Yep.
all right.
Not
Thank you.
yet.
Not yet, anyway, right? Well, I can do my shopping online, not pressing a button, so I don't know. could be achievable. Tomas, with respect to the conversation we had earlier, are you doing the same thing in Lithuania? There's an electronic health record. Is it being rolled out in Lithuania as a standard of care for remote patient monitoring or telehealth for patient management?
So of course, we do have national electronic health record system, but if we go back to the telemedicine and the virtual care, so we started our own journey up to post-COVID here, and as a university hospital, the large one, you can imagine how the load at the emergency department is increasing with the number of patients. And what we saw in our daily routine, there is quite significant percentage of unnecessary transfers from the remote hospitals. And as the remote hospitals are just sending patients to the university hospitals, you're starting to drown. And so we started just a pilot project on telemedicine in the emergency department, that every patient who would like to or who needs to go to the university hospital for diagnostics, for some kind of investigation or the consultation, they need to just have remote consultation via telestation with visual and audio contact. And so the physician of emergency physician in the university hospital can inspect, have a conversation with the patient and with the doctor as well. And then we can take a decision. Should the patient be transferred to the university hospital, or maybe he needs some investigation, or he can get a consultation from the specialist or from the emergency physician, and he can stay at his remote hospital. So we started with 12 hospitals. So we had 3 spokes in 3 hubs, and every hub had 3 spokes, and we're consulting in. What we saw at the beginning, that different hubs are working differently, because this hub who has an ambassador or who really believes in the technology, it had significant high number of consultations comparing to the others. And at the end of the project, we also saw the significant decrease of these unnecessary transfers to the university hospitals. So this has the impact on the national healthcare system as well, because the positive feedback from the ambulance was also got, and that means the ambulance is not just transferring patients from one hospital to another hospital, but they have more capacity to react to more urgent calls. And now the Ministry of Health was also evaluated as a successful project. So we got a permission to expand to not the entire nationwide project, but we expanding and covering more other areas. I see as a very successful project with a lot of benefits. And not, of course, all the healthcare system, the hospitals are quite rigid and not flexible.
No, really? Never heard that before.
You can imagine that.
Yes.
Now you need to speak with a doctor where is somewhere in another hospital and who wants, and the physician at the smaller hospital is asking, are you questioning my competencies?
Yeah.
Can I decide about the patient? But at the end, we got a positive feedback, because then the physician might have a strong backup, and he got the second opinion that he's doing quite okay, and his decision was very good, and the patient at the end feels safer.
But there are 3 points you just talked about. Go on, Max. I think you're going to just answer the question.
No, it's just that's very interesting, because I think that covers really that aspect also of bringing, let's say, qualification into the remoter areas of a region or a country, right? And I wanted to understand a bit better how much in your specific case also technology has enabled that, because I mean, basically calling up your colleague in the university hospital before sending your patient is something that we could have done 50 years ago, right? And is it that we now have a digital patient record where we can, jointly talk about the data that you've already gathered, or is it more the interaction that's easier now? How does that, what specific technology feeds into that?
Or did you take the patient away from the ER where they would have ended up and not end up there because it was a less trivial thing, if you wish, or less urgent thing, I should say.
Yeah, well, I think what is, let's also look from the patient perspective.
Yeah.
And he's having with someone is talking about his health and taking decisions behind of his. So we always want to engage the patient in the decision making. And then when we have this quite good station with a very good quality of visual contact, so the patient also is seeing the doctor in the room.
So it's is it on the phone?
No,
is that how it works?
No, it's a huge station.
Okay.
Yeah, with camera, with the screen. And a consultant in the university hospital has also 3 screens and a camera and microphone, so they can interact. You can even zoom very, very small things of the patient if you want to inspect. You can also
What does the patient see, though, on the patient side? Do they have to go to the hospital to do this, or can they do it on their phone? The question I'm asking
the patient. So
yeah.
this is a hospital, more physician to
so
physician.
it's physician to physician.
Yeah, so that means the station is in the emergency department, the patient is in the emergency department. You're just wishing or thinking just to transfer, then you need to consult.
Gotcha. But you're doing it completely differently. You're talking directly to the patients, right? How is that working technology-wise?
So it starts with a needs-based marketing approach. We advertise to the patient on the basis of the specific symptoms that they might be experiencing. So for example, in the context of the diagnostic tampon, we would ask the patient if they're struggling with vaginal itching or burning. So we don't ask the patient, do you think you have bacterial vaginosis? We ask them what their symptoms are, and then we walk them through a really simple educational journey where we use language that is really down to earth and digestible for the patient, because one of our key values is that you shouldn't need a medical degree in order to understand the workings of your body. If we tried a little bit harder to digest medical information, we could really raise the patient's overall educational level, which is super important for women's health, but for healthcare as a whole, particularly in areas like endometriosis and polycystic ovarian syndrome, where medical science doesn't necessarily actually have the answers to the questions. We need to be working with the patients more closely and believe the patient's experience and really integrate it into the delivery of care. So we start with this personalized marketing approach, which is followed by education. Education is a huge part.
It's all sort of web-based. There's no video call or anything right now.
There is a video call. So
there is a video
you
call.
can, it's at the patient's fingertips. It's up for them to decide whether they need additional care, whether they want to engage with the cost and the time that's associated with receiving additional care. And then what's available is our team of nurses and obstetricians, as well as other, again, niche specialists, so pelvic floor physiotherapists, nutritionists, that can provide holistic care for the patient.
Okay, amazing. And what are you seeing as challenges, Max? We talked about the doctors and I have always done it this way and why should I change? What other challenges do you face when you're rolling these things out? Particularly at the large hospital levels, right?
I think it's definitely this adoption kind of thing. Obviously, it's a new technology, so people have to kind of work it out. They're not necessarily trained for that. So that's the usual things that we're seeing. I think in some of the cases there's also an acceptance issue or thing.
On both on the doctor and the patient, both.
I was going to say on both ends. I mean, just imagine that solution that we see in the hospital, right? So there's, as a patient you're in the hospital, you imagine, that you have potentially the specialist or you want the best qualified person next to your bedside, right? And suddenly this person brings, that huge station with an expert remotely connected.
Here's your robot doctor.
So you start to maybe not trust the person that is right next to you, but that specialist that's remotely connected. So that can be something that has to be well explained and well explained, I guess. That's something, and then also on the doctor's end, I mean, you have to kind of, you have to acknowledge that in fact there's somebody else that might be better qualified in a specific case. You have to explain that to your patient, which is not not self-explanatory always, right? So that's something that we see. Other than that, I think. Or in many of these cases also, I think the benefits outweigh that hugely, right? I mean, as you said, I mean, this opens so much potential for patients to feel safer, to be in the environment that they feel safe in, to make sure that they're well treated. So I think that in the usual cases outweighs these challenges a lot.
Tomas, do you think we'll see this evolve into a way of changing the delivery of care where you triage first this way and then you see the patient? Do you think that's where you're heading?
Yeah, for sure. I think that's a matter of time. And we also just thinking where we could expand it. Of course, maybe just move to outpatient care when the patient, not just physician to physician, but patient to physician. The next thing, I think, we will go to triage. When the patient wants or needs to go, he thinks that he needs some emergency care, and you want just to regulate the queue and the workload, because you need to have all the specialists there. So maybe they can have the first triage on the AI-based or somehow AI-managed solution. When you just enter your symptoms, some measures like temperature, blood pressure, and
Which is what you're doing, Valentina.
Yeah, so you can get the risk score, and maybe he can stay at home taking some pill, or he can go to the GP, or he needs immediately go to the emergency department, or even the system can call the ambulance for the patient and bring to the hospital. And also the virtual care, so we moving, if we want to provide all the care and a good quality for the patients, and because the demand is increasing, and I think none of the healthcare system can take that situation. So we are moving just to shift to virtual beds, and just provide all the remote monitoring devices, gadgets, and collect all the information, and then take a decision. So the patients could be discharged earlier after the hospital, or maybe they have some assisted rehabilitation or surveillance in the future.
But it means, so go on, Max.
Yeah, I was going to say, I think the key aspect here is preparation, right? And that's also true for the solution that you have, right? I think doctors are one of the, or probably the only qualification where we expect to kind of, go unprepared at all. Like you go to your GP, he's never seen you potentially, you have a problem, and then you expect, in 2 minutes, you expect the perfect solution and walk out with some sort of prescription, right? In any other business, we go to a meeting, we prepare before, we Google the person that we're going to see, we think about the issue that's about the topic, we prepare, we write up a summary, and then, 1 or 2 weeks later, we sort of wrap the topic up, right? Medicine is totally different in that regard, and I think there's a huge potential in changing that, in being prepared for the interaction, which will make things easier, in providing some information before to both parties. That's I think the first change that we're going to see about how.
But who does that, right? I mean, you're doing it from your own startup perspective, and you're filling a need with this technology, triaging, and then hopefully, if I get my results and I get a PDF, I go to my OBGYN,
not just your results, but what we enable people to have is their entire medical history that's neatly systematized in a PDF that you can print out or email to your provider. Because what healthcare is currently doing is completely unreasonable, both for the patient and for the GP. You have these 8 to 10 minute appointments in which the practitioner is supposed to extract so much information from the patient. They're supposed to know all of the questions to ask. And for the patient, seeing a provider can often be intimidating, and you're on the spot. You have this like highly intelligent person next to you, and you might not remember everything that you want to say, especially when you're in this high pressure environment. So then the doctor doesn't have essential information that they need in order to treat you. So I think first, to do triaging well, it's important to give the time and the space to the patient to provide their medical context, and then the time and the space for the practitioner to review it before the connection actually happens. So the connection is a lot better utilized. You have that time that's spent actually in a valuable way. But for triaging in emergency care, or for any type of triaging to work, we can't just create like an ugly questionnaire. The user experience needs to be really carefully thought out, because otherwise the patient's not going to want to engage with medical jargon. They're just going to click on the responses randomly. They may not understand every word, and that's where, again, digesting information in a simplified way is super important, so you can meet your patient where they are and actually get the information that you need to treat them well.
So it sounds like we need to rebrand telehealth, because it's more than just tele, right?
And these days we already have chatbots who
Yeah.
can call you and give some question, ask some questions, and when you are giving the answers, he can already thinking and giving you another question just to specify in more details. So in the future, you will not be sure who's calling to you. So the
Is it a bot or a
assistant
doctor or
doctor.
whatever, right? Yeah, interesting. What are some of the challenges? We've got about 5 minutes. I think we'll open it up for a couple of questions, perhaps. I know we've said no, but we'll ignore the rules for a moment, just between us.
I must say
What
that
are the challenges?
I think what said, absolutely agree with the marks, but also we need just to focus more on patient education, right? We need just to give a good feedback from the patient that they trust the system, they trust the doctor, they know how to use it. The same from the physicians.
How do you build the trust, though? Because I know I can see Valentina's company building that trust, right?
So this is through the experience.
Okay.
Yeah.
Through the experience. And
Just stop penalizing people when they've researched their condition, when they come to see you. Like, let's just cancel that. Oh, did Dr. Google tell you that? You know, this type of approach. The patient should be actively involved in their care. You want your patient to Google their condition and to read the papers.
Sorry, Tomas, I cut you off, so keep going.
yeah, and also I think it's very important, very close collaboration with industry who's developing all these tools, right? And so the physicians,
tech companies
the physicians on the patients, and also we need support from the governmental part, because we need at the beginning get some kind of funding for implementing this new.
And is that what you guys did? You went? Did you work with the Ministry of Health?
We were successful, and we got a grant from the Ministry of Health just to implement. And when they see that you are just delivering the results and all the society and the population benefits, they are more eager to invest more, and especially so you need always to calculate cost effectiveness.
Max, any other thoughts around implementing this? What are some of the challenges that you have to think about up front if you're going to do this?
Yeah, I think upfront is a good keyword. I think when we see our projects being put together, I think that's the stage where we can really incorporate these types of solutions. I mean, especially in the service provider landscape, right? If you think, I want to, I don't know, create an outpatient cancer center somewhere. Why not implement, these types of solutions from the start? Think that through, think how it impacts your workflows, but also your patient population that you want to serve, and your business case, and all these things that you have to sort of plan in advance. And if you do that, then I think the likelihood of having a good solution in place rather than something that solves problems that you were sort of, designing in the designing phase into the project, the chances are much higher that this will be, enriching rather than just, firefighting essentially, right? With a solution that is, that is not good in the first place.
So quick, we've got a couple of minutes. One thing each, a prediction for this year, 2025 coming up. The adoption of telehealth and all of these capabilities. When you're working on it.
It's already 2025 almost.
Okay.
So I think
almost 3 more weeks.
So I think it will become a more routine in our healthcare services, and so we need just to make it absolutely transparent and safe for the patients that they are willing to use. Sometimes I think, okay, we have technology ready or almost ready, but are the human beings ready? Not sure. We need
Max?
to.
I think what we're going to see is instructions next year. So we're going to see not the remote connected app, but we're going to see instructional videos. We're going to see solutions that enable the patient to
more education.
To be educated about what's going to happen to them in the care pathway.
Last word, Valentina. Prediction.
I think we'll become a lot better at personalizing healthcare decisions and recommendations. Currently, modern medicine is still largely a very blunt instrument. And if we're really responsible guardians of data, and if we enable the patient to actually share more of their data, share more of how they're doing on their prescription, we'll be able to make more educated, intelligent recommendations. I think it's crazy that we live in a world where 30% of people can't process aspirin, for example. They can't metabolize aspirin, yet still we recommend it very, very widely. So I'm looking for more personalization through responsible data stewardship.
Super. I'm going to open up for a couple of questions. We've got about Ah, look at that. Hand went up straight away. No messing around. Nope. Not working.
Tries.
Hello, hello.
Ah, there we go.
Now it's connected. Thank you very much.
What did you think of these guys, first of all?
I think it's very challenging what they are sharing with us today. I think that telehealth is a big opportunity we have from private health. I mean, from healthcare provision. I'm working in the sector as a healthcare provider in Catalonia, and I think that my question is related to the acceptance from the citizens' perspective, this way of, new way of suggesting contacts. I think that one of the aspects we have here, besides what you're saying, we have to move into high-value actions, that it means probably avoiding referrals, etc. But one of the aspects is rurality. We have big challenges to reach or to provide services in so many areas, and that means that, and also we know that aging is a real thing, and we don't have probably enough human resources to provide that services wherever they are needed. So probably we have to move forward into a new ways of operating, new ways of providing services. So telehealth is an opportunity, but in your opinion, probably not everybody is a potential client of this kind of way of operating. In Europe,
What's the question?
the question is, in your perspective, what are the crucial elements that allow you to determine which are the ones that are going to accept or not to accept that kind of contacts?
Tomas?
So that's a very good point. And usually when you look at the population you serve and provide services, so you can take these, as Valentina, the young females or the educated people who are suited to work with the devices and with the technology. So it's very easy to interact with them and they easily accept everything. When we move to the more older population, like grandmothers, grandparents, and we need to have these solutions, technology simple. When you look at your grandparents, they all in Facebook looking at their grandsons and photos on interacting. That means we need just to make more friendly to the user, and it could be a solution.
I fully agree.
That's for patient perspective. What about for healthcare professional perspective? Because probably they are probably not so happy to have not the patient in front of them and having at home having the contact through a screen.
So you need just to be more. You need to make it more attractive to physician. So if the system crashes, if it's very time-consuming, it's like.
But surely it applies in the same way. The next generation of physician, I'm seeing this in the US, the next generation of physician, the residents that are coming through, are very technically savvy and are accepting of this.
If they see that the solution will help you just to summarize the previous healthcare records or have the medical history.
Do my job better.
Yeah. Then I will have more time just to interact with the patient. Speak first about his life. Sometimes it's very important for the patient to make a good bond, and then you can get a better trust from the patient, and then the outcomes are even better.
Any other question? We'll take one more. Anybody? Come on, there's 3 smart people up here doing crazy stuff with remote patients. No? You can find them outside afterwards then. Thank you very much.